Hey friends, today I want to talk to you about emergency room nursing. And emergency room nursing is very different, but yet same to all kinds of nursing. So I want you to think about, as we're going through this, is how is this the same and different from what you've already learned and been exposed to? So you can see in the picture above that we have people that are working hard at keeping patients alive. So think about the different interventions they have to get through. Prioritization becomes a huge piece of emergency room nursing. As we go, you'll see how they start to prioritize information and data differently than you might in another area. So think about those ideas of how do I make this my own, how do I make this unique, and how do I save a patient's life today? All right, let's talk about some prioritization and how we start to come to grips with who we're going to go see first or those choices. So we want to talk about stable versus non-stable. And you can see across the top that there's that nice spectrum that we've kind of already started to discuss in class, or if we haven't yet, we will. So thinking about how do we define stable versus how do we define not stable, and it's a shift and it can change quickly. So be very aware that it can change very quickly. So stable, breathing, talking, alert, doing their thing, coming into the ER or coming into the nursing environment, aware, right? Non-stable, not talking, not breathing, not alert, not answering questions, not really, none of those cranial nerves that we see, gag, cough, and corneals. Those kinds of things make you very, very unstable. So you can see by the grid that they use, this one uses urgent, more urgent, or most urgent, and then all the way down to less urgent. So it sometimes the terminology is different. Some places use immediate or resuscitation or emergent, and then other places use that kind of grade, that urgent spectrum. So think about when you're going through there, what are things that are going to be urgent? Obviously, big motor vehicle accidents. Shootings are usually considered urgent. Stabbings are usually considered urgent. Heart attack, stroke, those things that where we have to immediately do something or the patient is not going to survive within minutes. So this is a triage ability that we are going to have to go through. So if somebody's coming in and they're not screaming and they're not in pain and they're not all that stuff, they can kind of be put on the back burner a little bit versus the person that is unresponsive, bleeding out, those kinds of things. Those ones have to be seen sooner. So unfortunately, in the ER, it's kind of an interesting one because the patients that can complain the most are the ones that can wait the most. So not always the happiest people, but the people that can't complain are usually the ones that need to be seen rather quickly. So as you're thinking on patients and as you're working with them, think about urgent versus not urgent, or emergent, immediate resuscitation. If I don't step in within minutes, they're going to be dead, versus somebody that's coming in with an ear infection because it's after the pediatrician's office closes. And those are all reasons people come into the ER. The ER is a jack of all trades. All right. And so they have to be able to assess a situation with observation very, very quickly, and then they can start collecting that data. So let's talk about primary and secondary survey, but we're going to start with primary, obviously, because it's first. So that's our first survey. So you can see as we've got things written over here that it is airway, breathing, circulation, and disability. So A, B, C, D. I do tend to say that A should be alertness, but I have to change the world in order to make that happen. So right now, with primary survey, the way it's written out and in your books and all this kind of stuff, it's airway, breathing, circulation, and disability. So let's work through a few of these. Airway. Is it clear? Can they breathe? Can they not breathe? What's going on? Do they have a hot dog in their trachea? Do they, are they having an allergic reaction that's closing everything up, and so they can't get that airway open and through? So that's our first thing that we're going to be checking and assessing. The other thing is breathing. Are they easily breathing, or is there something going on? Are they having a flailed chest? So their breathing is like that asymmetrical chest rise and fall, which is really the only time I've ever seen flailed chest or that asymmetrical breathing is when we've had somebody that has broken all the sternal areas. And then, so, or are they coughing? Are they able to clear that airway? We have lots of interventions for all these kinds of things that we'll kind of start to go through as we go through out the semester. But think about the interventions you've already started using in your med-surg classes, in your health assessment class. What have you already learned with some of the interventions to get people breathing? CPR is one, right? The bag mask valve. We can get people breathing if we have to and we need to. Circulation. So what kind of assessment data are you going to collect for circulation? One, their skin color is such a great thing to check. If someone has pale, dusky skin, you know that we're not perfusing very well. We're not circulating that blood through very well. So we want to make sure that we're assessing that. You can always assess pulses. We should always assess pulses closer, especially if people are coming in with problems. So we want to make sure we've got those core pulses. Then disability is considered neuro, which is kind of an interesting one to me because, again, I'm a head trauma nurse, so my thought is neuro is always first, right? When you walk in a room and someone doesn't respond to you, that's a neuro assessment. But we're going to go down into the D because that's where we're going to keep it. So disability, you're going to do those neuro assessments, those cognitive things. You're going to be asking them questions, seeing how they're responding. Do they know where they are? Do they not know where they are? Are they able to respond? Are they not able to respond? We have other scales. You've got the Glasgow Coma Scale, which is a good one to know and a really simple one. They do the APVU, which is that, I had to write it down because I haven't done it, but it's alert, verbal, pain, and unresponsive. So AVPU under disability is that alert, verbal, pain, unresponsive. But again, that's something that you're gonna just kind of assess naturally as you come in the room. Remember, we make all these fancy words and technologies and terms for things, but sometimes it's just common sense. Like if you go in and say, "Good morning, John," and John doesn't respond to you, he's not alert, right? So think about the things you do naturally as you go into a room or as you go into a gathering of people. You're assessing everybody's alertness. I'm opening your eyes, friends. So you're going to be there at a party and you're going to be like, whoa, so-and-so in the other room is not doing so hot. Nurses start to see those kinds of things because we naturally start to progress. Now, kind of funny, when I talked to an ER nurse about the primary survey, she kind of looked at me and was like, what are you talking about? Because she is so naturally ingrained all this in to what she does every day, she doesn't think about it as a primary survey. But as we're learning those skills and those tools and those techniques, that's how we're going to look at it as a primary survey. So we've got A, B, C, D to start, and the next slide's going to go over the next ones. So if you like the alphabet, this is going to be really good for you, right? We've already gone through the first part of the primary survey, A, B, C, D. So airway, breathing, circulation, and disability. So we've already covered those. Now let's cover the rest. E, F, G, H, and I. So E is expose. Expose those people, friends. Like you want to look at them head to toe, make sure that there isn't stuff missing. This gets really, really important for like gunshot wounds because you want to make sure that you see the exit wound or if the bullet exited at all. Bullets are kind of funny. They like to bounce around inside the body. So it's not like I know in the movies, they're like straight shot and it goes straight through them. Sometimes it does. But oftentimes bullets, once they hit the body, they start kind of bouncing around. And so that can cause a lot of problems. So we want to see if we have exit wounds. You may want to see if you have burns on things like people. I've had patients come in where they've poured hot coffee on themselves and everybody's like, oh, they burned their belly from the hot coffee. But then what they didn't realize was maybe it was an elderly resident and they had a brief on. And so then they've burned all that perineal tissue too. So it's really important to make sure that we're exposing them. That is why we have nice scissors that cut clothes off because we have got to see everything. It also lets us find other things like we find drugs oftentimes in pockets, cracks, and orifices. So kind of an interesting way for us to expose and really see what's going on. F is for a full set of vitals. Now, if you're taking this long to get a full set of vitals, we've missed a few steps probably in my thought, because when you're in the ER, it is a well-oiled machine. Like everybody takes their jobs and they just start going. I've been a patient in the ER a couple times and I've watched this process and I just sort of sit in awe of them. The ICU has a very similar process where we all start taking our tasks. So, but you do want to make sure we get a full set of vitals. The other F is for family. Family can be a huge challenge in the ER because you're just trying to figure out what's going on, and you've got all the emotion and the intensity of that coming on board. So make sure that you've got people helping with that family piece and keeping families in the loop. G is get on monitors. Again, if you haven't really done this, we're kind of missing a few steps. I think, again, that's part of that team. We just start doing stuff. Like, we like our tasks. Tasks are nice because they make us feel comfortable and they make us feel like we're doing something. So we want to make sure that we are getting them onto those monitors, getting those vitals, getting those numbers, so we can see where our baseline is, and then that kind of lets us know, like, are we, or how bad are we, and where are we having to start going. The other thing is to give comfort, and give comfort doesn't always have to be medications, but totally can be medications. Give comfort can simply be talking to the person. They've got all these people on the end of their body doing all this stuff. Just simply being at the head and being like, hey, sir, we're going to get you on a monitor. We're going to get a blood pressure on you. Can I get your temperature? We're going to be cutting off your clothes. That can feel very, very violating, especially if a person is even slightly awake. So we want to make sure that we're giving comfort because we're telling them what we're doing. That education is very comforting for people. H is for history. If we can, we want to get as much history on a patient. Like, did you have shellfish today? And that's why we're having all this swelling and stuff going on. Do we have an allergy? Medications that we're on. I don't care necessarily if somebody's on Zyrtec or any of those like really basic meds, but if somebody's on aspirin and they're coming in with chest pain, that becomes very, very important for us to know because that changes our dosage of the aspirin. So getting that history as best we can is great. That can also be something that family does. Sometimes family is really in the know. And then the other thing is, again, inspect. We want to inspect everything. We want to inspect the bumps. We want to inspect all the parts and pieces. Now, in the ER, let's just be honest, they have so many patients, and they have somebody from ear infection to somebody crashing and burning on them. So I'm just going to be honest, if an ER nurse gets all the way through all of this stuff with history and inspection and expose and all that stuff, fantastic. But a lot of times that's not their priority. Their priority is to stabilize and save a life. The ICU, the floor, wherever else this patient is going to go, that's their job, right? Like, we can start doing that up in the unit. Sometimes in the ER, I don't think I get super great reports from those nurses because they're so busy, because there's so many other pieces going on. They've stabilized the patient. Now they just need to get them up to us, and we can maintain and start to restore and start to see what we really need to do. The ER is really kind of that Band-Aid space. Like, they're going to put pressure on the bleeding wound, but they can't fix the bleeding wound. They got to send them to the OR for that, and then a lot of times they come up to the unit. So it just really, really depends on what your patient is coming in for, because it's so vastly different. Versus, the ER goes from everything from sending them to the ICU, sending them to a different hospital, to sending them home with some antibiotics or, some pain meds or something like that. So it's a very cool area. I think of ER as, like, I did lifeguarding for a long time, so I think of ER as lifeguarding, because you sit there for a lot of times, got your whistle and you're twirling it and you're sitting there doing your thing. But then all hell breaks loose because something comes in. So the ER is kind of a fun space to work if you like that, being able to think quickly on your feet and process and go, and not always know what's coming in and what's coming next. I'm not an ER nurse, but I have a friend who's an ER nurse. So I asked her what were her things that she wanted new graduate nurses to know about the ER. And what she wanted them to know was stay calm, leave your judgments at the door, and give really good report. Because she said those are the 3 things that she had to learn so hard as she transitioned into ER nursing. Stay calm. Your energy is transferable. So if the family is already anxious and tense, and you come in with anxious, chaotic energy, you've just transferred that energy to the patient and the family, and it's gonna make it worse. So you have to practice staying calm. on the outside. You can be challenged and freaking out inside. I always say that. I'll be shaking in my sneakers, but I will not show that on my face. Now, and in the nurse's station, I might lose my bit a little bit when we're going through this, but that energy is contagious. So make sure that you're doing that afterwards, and we're working through the process as we're there. If you're losing your cool, step out of the room, because that's not going to help them any. Now, judgments. People come to the ER for lots and lots of reasons, and we'll talk about that in the next slides or so. But we have to leave our judgments at the side. It's none of our business why they're there. It doesn't matter what happened that got them there. All that matters is that we are there to help them. So make sure that you're very careful about your judgments. And sometimes you don't realize them until you're faced with them. So be a little bit self-aware of like, ooh, this is making me a little cringy inside. This is making my stomach have a little churn. Maybe I've got something here that I need to just kind of deal with, but not now. We'll deal with that later. And then the other thing is report. Make sure report is concise. Make sure it is pertinent data. Make sure it is not all the fluff. If you are calling a doctor or giving a report to a colleague, you want the important stuff. We don't care about Claritin and if they have seasonal allergies, unless that's the reason they're there, which if Claritin's a big deal, then that's probably not an issue right now. But so those are the things to think about as you're working with patients and when you're working with your team is what is it that I need to paint a picture of to make sure that my doctor is getting the best report and the best idea of what's going on. The other thing is in report, don't say a patient has a UTI. That's a diagnosis and you're giving a preconceived notion. Doctors and people don't want that. They want you to give them the data. Say patient is here with burning on urination, itchiness, pain, bleeding in the urine, whatever it is. You can totally paint the picture of a UTI if that's what your patient's here for, but you don't want to say UTI because it may not be that. They may have renal cancer or something else completely differently going on. Now, are we going to explore the UTI route? Absolutely. But those come up negative and you're like, wait a minute, what's going on? If you have that preconceived notion of a UTI, you're going to get tunnel vision and you're only going to see that. So you want to really make sure that you are paying attention to the words you use in report. Keep it simple. So stay calm, leave your judgments at the door, and give a very good, articulate, simplified report. You don't have time for all the fluff. Keep it simple of what's going on. All right, so let's talk about the fun of the ER, what brings people in. Now, what we must understand with the ER is that every hospital that has an ER has to see anyone that walks through their door. They cannot refuse care. I think that's a really important thing to understand as we see the challenges that come with the ERs and the hospital costs and all this kind of stuff. It doesn't matter if a patient has money to pay, insurance, anything, they're illegal, they're a citizen, it doesn't matter. The ER has to see everyone that comes in. We cannot dump a patient onto another hospital. Now, we can ship a patient to another hospital if they need specialized treatment. So like in Lincoln, where the Bryan West is a trauma hospital, we can ship a patient to St. E's because it's a burn unit. We cannot ship a trauma patient to St. E's because they just can't pay, so we're not going to do it, or we don't like this patient or whatever, and we can't ship them. We have to stabilize first, no matter what, and stabilize the best we can, and then we can get them to the level of care and the specialized care we need. Be very aware of that. That can be a huge challenge. People think that we're just shipping them, and no, we cannot refuse care to anyone. So let's talk about some of the stuff that people come in with. So they come in for accidents, car accidents, gun accidents, work accidents, farm accidents, any accident that's out there that causes someone to have some sort of injury that can be anything from a broken foot all the way to a strangulation because their scarf got caught in the machine. So any kind of accident in there, not to mention car accidents. Please wear your seatbelts. Please wear your seatbelts. and any kinds of accidents that are out there. Hitting deers, I see a lot. We used to see a lot of people for hitting deers. Disease process, where a disease process has gotten so far out of hand that they can no longer care for it. So again, it's that idea of stable versus non-stable. Stable can go to, their local doctor or whatever, but unstable, once their disease process hits a certain point, they've got to come in. So COPD exacerbation, DKA for their diabetics. We get people that come in because of heart attacks, because they've had high blood pressure, strokes, any of those kinds of things. So disease process that once it has gotten out of control and needs immediate intervention, or people that didn't know they had disease, and all of a sudden they come in and they're like, I've got a headache, I'm not feeling good. And all of a sudden we realize, oh, they have hypertension, they have all these other things that are causing it, but now they're having a stroke or something going on. Financial challenges. The ER, unfortunately, because they can't refuse care, they have to give care to everyone. Patients that do not have insurance, patients that are illegal, patients that have other challenges that are socioeconomic in nature, the ER will see them. So again, you get the mom that comes in with a kiddo with an ear infection because they don't have a primary care doctor. They don't have someone to go to. So those are kind of a challenge piece that gets kind of mixed in with all the mess of the ER. Weather can bring people in. We're in winter right now. Frostbite. A ton of patients come in with frostbite. Our homeless population comes in with frostbite. We see a lot of frostbite in the winter. On the other side, during the summer, we see a lot of heat exertion and all those kinds of things, those heat related injuries, sunburns that get so bad. Oh my gosh, I've seen so many blistered burns that it's just, they make me want to cry. But weather can cause such huge issues, that exposure to the elements. That's why it's dangerous to be outside and in the wilderness for too long, because there's so many things that can happen. And then unfortunately, violence. Violence brings people into the ER. Working in Omaha, I saw shootings. I've seen drug deals go bad that involved violence. I've seen people getting beaten up to the point of needing ER and services and stuff. So there's violence out there. Not to mention there's mental health crises that bring people in because they become unstable in their own mental health. Suicides are a sad one that come in. So there's a lot of things that bring a patient into the ER. Trafficking can bring people in. So that's why it gets really important for us to recognize signs of human trafficking, abuse, child abuse, elder abuse, any of those abuse kind of things. Rape brings people in. So we have a lot of things that bring people into the ER. And something we have to be really careful about is to save our own mental state. We get a really dark sense of humor, but those patients don't need that dark sense of humor. So keep the dark sense of humor at the nurse's station. Not going to tell you not to have it because, again, it is a survival technique and mechanism. But make sure you don't bring that into the room, because people that are going through these situations don't need that crass nature. So make sure you're just, again, that's kind of just that self-awareness as you're going through. But those are the things that can kind of bring patients in. So think about the disease processes you've already learned about. So you already know a lot of them. And think about when they become unstable. And then we'll talk about the different kinds of things that we have to start doing as we go through the next few units as patients are going through those kinds of cares. Let me know if you have any questions, and we'll keep working together. Well, nothing would be fun without a little challenge. So what I want you to do is I want you to just draw a quick Venn diagram on your notes or wherever you're keeping any of your information. And I want you to put ER nursing on one side and a different kind of nursing on another. One you're interested in, one you've had exposure to, one you already have done. I don't care. Gone to clinicals, thought was fun, whatever. ER nurse on one side, a different type of nurse on the other side, and I want you to compare and contrast. How are they the same and how are they different? The same stuff goes in the middle, and the stuff that makes them unique goes on the side. I will have a link that you can upload a picture of your Venn diagram onto, and we'll kind of see what everybody's thinking about how things are the same yet different.